Hello, Professor Michalczyk and policy students. My name is Gayatri Singh, and I am a clinical professional in the fields of social work, psychology, and integrated medical and behavioral health in Louisville, Kentucky. I'm a practicing autonomous psychotherapist at Access Behavioral Health here in Louisville, Kentucky, and also a pre-doctoral intern at Kentucky Anna Pulmonary Associates. I work with a range of populations from the severely mentally ill to the LGBTQ, etc. My specialization includes working with the adolescent to adult populations, since I love the plethora of diversity that they tend to offer. Today, I'll provide an overview about working with the LGBTQ population with an emphasis on transgender patients in a clinical setting such as ours. This will be done in a question and answer interview format as requested. Number one, first, it is very important to understand what it means to be transgender or gender non-conforming. So basically, here's the definition. Individuals that experience discomfort or distress that is induced or caused by a discrepancy between a person's gender identity, that is whether they identify themselves as males or females, and that individuals' sex assigned at birth are considered transgender. For example, the associated gender role and or primary sex characteristics are at odds. It is important to know that gender identity is a social construct and sex is a biological construct. Number two, why do transgender individuals need mental health care? Well, it is important to note that no formal epidemiologic studies, that is, the study of the course of disease, has been performed to determine the incidence and prevalence and the extent that persons present for professional help, as well as the ability of clinicians to diagnose this disorder may vary amongst countries and different cultures. Not all patients with gender identity disorder or gender dysphoria make it to specialists, so the numbers you may see in the literature may be an underestimation. Most patients coming into treatment may have traditional complaints such as depression, anxiety, and distressing impacts of functioning in social, occupational, interpersonal, or legal situations, which are kind of precipitated by chemical dependency concerns or suicidal features that they might tend to utilize to self-medicate and to kind of deal with whatever circumstances that they might be faced with. One common clinical observation is that these patients have a very strong conviction that they belong to another gender and emotional disposition. Patients may often feel uncomfortable being called by their birth names and may prefer to be called by their adopted names. For example, Joe, who was born a male, may want to be called Josephine. It's clinically strengthening on our parts as clinicians to respect the patient's request to be identified by their adopted names. This also helps with rapport building. All right. Number three, how does treatment for someone who is transgender compare or differ from others in general, and especially the rest of the LGBTQ community? Ideally, every patient presenting to treatment devoid of their population status should be diagnosed based on a thorough clinical history with collateral information collected as available from friends and family, plus a mental status exam should be conducted along with additional testing to review clinical concerns such as depression, anxiety, bipolar disorder, ADD, etc. Historical data is kind of critical because that would ascertain how the dysphoria developed, how the patient has adjusted so far. That is, their strengths, their support systems, self education, resiliency factors, medical care, etc. Further referrals to other clinicians in the community may need to be made to evaluate for other disorders of sex development that may not have been diagnosed at birth. Let's say, for example, someone that was born intersexed. It used to be called being hermaphrodite, where some hormonal or chromosomal testing is recommended. However, it is equally important to note that gender dysphoria may occur with or without a disorder of sex development. All right. Um, Number 4, what is the legal process of physically transitioning as it involves mental health care? Well, I'm unsure about the details of the legal process involved, so I'm going to defer this question to lawyers that may be able to offer more insight and accurate information about the same. I bet you have some lawyer friends, etc. Contact them, talk to them, because I don't have the latest information about the legal aspects. All right. Number 5, is it fairly easy for individuals that identify as transgender in some sort of way to get set up with a mental health provider? Well, unfortunately, there is a range of opinions about treatment protocols. However, in general, treatment should be tailored to each person's needs, especially as it relates to his or her goals for gender expression. Some clinicians believe that patients' feelings of gender dysphoria can be relieved by altering a person's anatomy, that is, via hormones and or surgical procedures, so as to conform with the patient's subjective gender identity. Other clinicians believe therapy should try to help the patient learn how to live more comfortably within his or her own body. These clinicians may believe that dysphoria may resolve without any sort of hormone therapy or surgery. I personally, as a clinician, believe that patients should undergo extensive, consistent medical and psychiatric assessments within a multidisciplinary team for at least 24 months, that is 2 years, and in some cases more, before undergoing any sort of irreversible biological interventions to eliminate any doubts, regrets, and to make a proper educated decision. Whatever the case, rapport appears to be the most crucial factor in treatment. If a patient feels no connection with the therapist or treatment provider, it is the ethical responsibility of the clinician to suggest a referral elsewhere after researching the patient's needs. All right. Number 6, are there many gender affirming mental health providers in the Louisville, Kentucky area? Well, this was a tough one for me. I do not have any hard statistical evidence to support this either ways. However, anecdotally, it can be speculated that the level of training within the mental health professionals in the area varies greatly. Subsequently, it may compromise the quality of the services being provided. Number 7, does health insurance generally cover mental health services for transgender people? If so, what are the limitations on the coverage? Well, again, it depends on the context. There are provisions for mental health services made for traditional issues such as depression, anxiety, bipolar disorder, schizophrenia, etc. However, when it comes to specialty care for specific transgender based therapy, there may be some red tape involved, especially in the context of working with the multidisciplinary team for pre-operational and post-operational treatments. Then coverage may be limited since it is considered to be under the umbrella of elective procedures and may not be covered in its entirety or at all by insurance providers, which is sad. Number 8, how much interaction is there between mental health providers and primary care physicians or physicians involved with transitions? Well, although a multidisciplinary specialty team approach is most appropriate when available, the sad truth is that it is a rarity in reality due to busy, conflicting schedules, geographical distances, etc. Some clinicians believe that it may be important to advocate for the patient in the community and in certain institutions in which the individual is involved, which is like the court system, the employment system, the medical system, etc. It can be immensely time consuming and taxing, thus making it secondary to the treatment process. Therefore, whatever the case, patients should be able to provide informed consents with realistic expectations about possible outcomes. Um, I hope that helps. Number 9, what other limitation to access of services have you observed, especially in Kentucky? Where do I begin with the limitations faced by the LGBTQ population here in Kentucky? There are laws against homosexuality. Same sex unions are not recognized legally out here. Additionally, adoption and parenting rights are not permissible, which is unfortunate. Like one of our patients are struggling with that right now. The medical procedures they undergo, whether it is for gender reassignment or in vitro fertilization, are considered elective procedures and not covered at all by insurance panels. Although public and private employment discrimination against state workers based on sexual orientation or gender identity is considered illegal, such discrimination kind of continues. There are housing disparities, although there are non discrimination ordinances on the books. Unfair practices kind of continue. Due to a lack of knowledge, education, or ignorance, families invariably ostracize these individuals. That it kind of increases homelessness, chemical dependency issues, prostitution, and it's kind of rampant in this population because of that. However, the good news is that Kentucky does permit post-operative transsexuals to amend their sex on their birth certificates. So that's great. One thing out of so many, but it works out. We have to start somewhere, right? So this is it. Number 10, obviously, transphobia is still an issue. Does the licensing board for mental health care providers have an official policy on gender reparative therapy? Well, the National Association of Social Workers, that is the NASW, recognizes the considerable diversity in gender expression and identity amongst the population. They should be afforded the same respect and rights as other people. NASW also supports the rights of transgender individuals to receive health insurance and other health coverage without discrimination on the basis of gender identity, and specifically without exclusion of services related to transgender or transsexual transition or sex change, as they usually call it, in order to receive medical and mental health services through their primary care physicians and the appropriate referrals to medical specialists, which may include hormone replacement therapy, surgical interventions, prosthetic devices, and other medical procedures. As far as I know, APA follows the same policies, that is, the American Psychological Association, the American Psychiatric Association. They follow the same procedures and more. Number 11, the DSM 5 removed gender identity disorder and replaced it with gender dysphoria. Has this made anything easier in the mental health field or created more problems? Well, part of removing gender identity disorder and replacing it with gender dysphoria in the diagnostic label is not only more appropriate and consistent with familiar clinical sexology terminology, but it also removes the connotation that the patient is disordered. Ultimately, the changes were made to kind of respect the individuals identified by offering a diagnostic name that is more appropriate to the symptoms and behaviors they experience without jeopardizing their access to effective treatment options. It is too early for me to say whether it's made it harder or kind of easier or created more problems, since these changes officially came into effect in October 2014. So it's just been a couple months. It's hard for me to say, you know. To make it easier, I have added a list of frequently used local resources for those of you interested in accessing care materials for the LGBTQ population. Well, I thoroughly enjoyed making this presentation for you, and I hope you gained something of importance from it. Thank you, Professor Michalczyk and students, for giving me this opportunity. I've come full circle from where I was. I was in your position in 2004, attending the very same class that you are right now, to where I am today. So this is really exciting for me. And all the best in all of your future endeavors. Feel free to contact me in case you have any questions or concerns. My information is given on the little resource brochure that I handed out. All right? You take care. Bye-bye.